Hello and welcome to this evening's event, and thank you all for joining us for the third instalment of our GP webinar series in 2023. In tonight's webinar, Dr. Conal Twomey, Senior Clinical Psychologist with St. Patrick's Mental Health Services and Adjunct Associate Professor with University College Dublin, will explore the topic of personalities in clinical practice. This hour-long webinar will focus on understanding the personalities of service users from diagnostic, contextual and dimensional approaches. Increasing GPs' knowledge about each of these approaches to personality and their associated pros and cons will help to inform care planning and promote open discussion of clinical issues relating to personality. ICGP CPD certificates will automatically be sent within the next 4 weeks to any GP who is registered and is attending live this evening. There will also be an opportunity following Dr. Twomey's presentation for a short Q&A, and you can submit your questions via the Q&A function on your screens throughout the webinar. So we'll get started. Let me introduce you to tonight's speaker, Dr. Conal Twomey. You're very welcome, Conal, and thanks so much for your time this evening.
Thanks a lot, Katie. It's great to be here. I'll just share my screen, I think, and get going.
Yep.
If that's all right. So let's see if this is okay. Is that the right screen, Katie? Can I just check?
Yeah, that's perfect. Yeah.
Okay, brilliant. Okay. Yeah, as Katie was saying, I'm going to talk today about understanding personality in clinical practice from 3 different kind of perspectives: diagnostic, contextual, and dimensional. So I guess it's kind of a brief run through of those 3 areas, and then looking at some of them in a bit more depth and looking at the pros and cons of each, or the kind of advantages or disadvantages of each. So start off by asking or putting out there, what is personality? What do we think of when we think of personality? And we've been looking at personality as human beings since hunter-gatherer times. We've used personality to evaluate who'd be a good mate or who'd be a good hunting partner, and so on. So it's always been adaptive to judge other people's personalities. And in 2023, the way we often interact with personalities is sometimes it can be a little bit of a judgment about somebody else. Somebody that we know socially, maybe we often talk about their personality, maybe somebody we work with. Maybe we'd say Emma is great crack on a night out, or Cian is grand once you get to know him. And then there's can be negative kind of connotations with personality. Sometimes we might say Barry has no personality, or even when we kind of judge people the most, we might say they might have a personality disorder or something. Sometimes it's kind of used in kind of everyday speak, I suppose. But I suppose the thing just to bear in mind with personality is that it doesn't have to be kind of a judgmental thing. So we don't have to kind of rank people according to their personality. It exists out of social context too. So it's not just how you function interpersonally or get on with other people. There's other aspects of personality, like conscientiousness or openness to new experiences, for example, that are kind of outside of social context. Personality changes over time. So if you think of your personality 10 years ago, and then 10 years before that, you will have had the experience of gradually changing your personality over time. And while personality doesn't change from week to week over the course of a lifespan, it changes quite a lot. And so does your peer group's personality as you move through life. And I guess there's a kind of a growing awareness that you can actually work on aspects of your personality. It's not set in stone. You can, so for example, if you're not an assertive person, if you've struggles with speaking up for yourself, there's a good evidence base that you can actually improve that with assertiveness training, for example. So there's parts of personality that you can work on, if you like. And if you were to look at the definitions of personality, there's lots of them out there. There's no real kind of overall definition that's agreed on, but we can think of it in terms of characteristic patterns of thinking, feeling, and behaving, first of all. So it's kind of what you normally do or think or feel in a given situation, or it's kind of like your tendencies as a person. And this old one, from Cattell, that what predicts a prediction of what a person will do in a given situation. So if you know your best friend or someone, maybe your partner, if they were in a given situation, if you can imagine them interacting with people in a given situation, you could maybe predict how they would react if you know them well. So I guess it's kind of like overall, it's your think, feel, behave tendencies together can be thought of your personality. There's a lot to it, more than that, but that's kind of a basic kind of overview of it. And then if we're looking at personality in clinical practice, so what we're going to look at today, as I said at the start, the first one would be diagnostic approaches. So these would be based on DSM and ICD diagnostic systems. This would be kind of mostly the medical understanding of personality. What comes up here is personality disorders. So like, for example, borderline personality disorder. And it's kind of, to note here, it's kind of categorical, sorry. So you either have a personality disorder or you don't. And it's not really continuum based because it's based on a diagnostic system. And then we have the second approach I'll look at tonight is contextual approaches. So this is really, if you think of somebody's personality in reaction to things that have happened to them in their lives. So if you think of attachment difficulties that people might have, attachment relationships growing up with people close to you, and how that affects your adult relationships in later life. We're looking at kind of interpersonal things here, and then the focus is on what happened to you and how has that shaped your personality. So this is attachment often comes up in clinical practice in MDT discussions as well. And then the final approach, which I'll probably talk about the most, is dimensional approaches to personality. So looking at personality as on a continuum, looking at all the different kind of aspects of personality, whether you're in the low range, the average range, or the high range. It's looking that we all have these commonalities really, and we're just somewhere in the distribution. And here you can have a symptoms focus where we look at kind of problematic aspects of personality, or we can have a universality focus where we're kind of highlighting the common parts of everybody's personality as well. So we'll kind of come to that in a few minutes. But I guess looking at the first diagnostic approach, I don't know as GPs how familiar you will have been with this, but I'd say you know at least some of these terms, and you will have been introduced to them, or people would have been maybe when you're talking to a consultant psychiatrist or you're doing referrals, you would see some of these clusters of personality disorders. So you have the cluster A personality disorders, which are related to sort of paranoia and kind of, sometimes it's referred to as peculiar type of personality, schizoid and schizotypical personality. Cluster B, which is probably the most prominent form of personality, where you have antisocial, borderline, histrionic, narcissistic. And then you have cluster C, which is kind of really kind of avoid, like how you relate in relationships. Are you avoidant, or are you kind of overly dependent? Or do you like to kind of control things? Obsessive compulsive personality means that you're kind of highly over controlled. So that's the DSM criteria for personality disorders. So you can just Google that and kind of be familiar with it if you feel that's important for your work. So looking at just a couple of the main ones, with borderline personality disorder in the DSM, there are 9 markers of that, and I suppose to be assigned the diagnosis, you need to have at least 5 of these different conditions. So it could be any mix of 5 of those 9 in front of you. So for example, fear of abandonment, unstable, intense relationships, unstable self-image, rapid mood changes, impulsive and dangerous behavior, self-harm or suicidal behavior, persistent feelings of emptiness, anger management issues, or temporary paranoid thoughts. So a kind of a grouping of those would point to borderline personality disorder. And again, just bearing in mind, it's that all or nothing approach. So you either kind of, if you have those 5, let's say, out of that, then you might get that disorder diagnosis. But if you think of yourself, even looking at those different parts now, you probably think, oh, I've had a little bit of that and a little bit of that, whatever the different parts are, at some stage in my life, during my development. So that's one of the issues with diagnostic systems, is it doesn't really take into account that these issues are often spread in the normal range in the population as well, because it's not continuum based. Another prominent one is obsessive compulsive personality disorder. So a personality disorder that causes an obsession with order, perfectionism, control, and a specific way of doing things. So we have excessive doubt here, maybe overthinking is another way of saying that. Difficulty compromising once you're kind of set in your ways, or you're set on a certain route that you want to go down. Unwilling to throw out objects, perfectionism, and sorry, my microphone just dropped there for a second. Yeah, so there's a number of symptoms there, but it's all to do with really a lack of flexibility and a kind of an over control tendency. So that's the diagnostic approaches. If we move into the contextual approaches, we can look at concepts such as attachment and interpersonal styles, and figuring out what happened to you kind of in childhood and how does that translate into your adult personality. So it's good to be aware of attachment styles here. So these refer to how securely or insecurely you're attached to your parent figures, or family members growing up, or sorry, as a child, and how has that translated into your close relationships when you're older. So we can be securely attached. So that means we have that balance of independence, but we're also kind of can get on well with people. We're secure in ourselves. We have a relationship with ourselves and the other person. But then the other 3 are more kind of insecure attachment styles. And again, you might see elements of these in yourself. I know I certainly do. So if you kind of have an anxious or preoccupied attachment style, you would be hypersensitive to rejection. If you have an avoidant personality, an avoidant attachment style, you would be hypersensitive to social interactions. You might find them overwhelming, or you might find close relationships overwhelming. So you might decide that you want to avoid them, or you might avoid them as a kind of a coping strategy. And then finally, if you have a disorganized attachment style, you might feel that relationships are very stressful and overwhelming, and you kind of, in fights and stuff in relationships, arguments and things like that, you just sometimes feel like you can't cope with them. So you want to so you've difficulty regulating your emotions in those situations, and all of those kind of come from, or their origin is in childhood experiences. Another related concept is something called epistemic trust. So the theory here is related to one of the most important tasks in life is figuring out who we can trust and who we shouldn't trust. And we need to use a balance here between perceptual information. So that's kind of like, perceptual is like the situation. So if you had a salesman, perceptual information would be, you would know yourself, oh, that's a salesman, so maybe I shouldn't trust that salesman because he's trying to sell me a car I don't want. But so you have to balance that type of information or experience that you have in life in different situations. You balance that with ostensive information. So that's how people appear in the situation. So the salesman might be very friendly and say your name a few times and smile and joke. So that's also information that we have to balance. So we have to balance our experiences from the past plus the current situation. And sometimes people have a balance where they've been through traumatic events. Their perceptual information might be kind of way a lot heavier than the current sense of information. And then if we're naive, in a way, if we're over trusting, it would be the opposite balance. So this kind of, it's sometimes people talk about personality in terms of trust issues, like how trusting the person is or how open they are to other people. And looking at it in this kind of what happened lens, you're kind of focusing on the events and the stages in life that have happened. So what's a person's experience in life, or what's the values of the culture that they're in, or the country that they're in, or their sexual orientation, or what school they went to. You're thinking of all of these contextual factors shaping personality. And then you have life events as well. So it's been found that big life events on their own can really shape your personality. For example, a trauma shapes your personality, or relationship events. Having a really good relationship where you are nurtured by your partner can really affect your personality, and so can a bad relationship as well. And there's other things there, like life events, like changing job, for example, is another big one. You kind of sometimes become the person that the job wants you to be. And the psychology is probably one of those. So all of those are kind of contextual approaches to personality. So attachment, trust, and what happened to you. And then the final approach is dimensional. So again, as I said earlier, this is kind of like everything on a continuum. The approach is we all have some level of different aspects of personality. And it just is a matter of, are you high on certain aspects? Are you low on others? And we all have a mix where we might be high on some, low on others, and we might be in the average range. So it's kind of a normative look at personality. And in clinical practice, that can be done from sort of not a diagnostic, but actually a symptoms-based approach is the first one. So this is kind of looking similar to personality disorders, but it's because it's looking at the problematic aspects of personality in isolation. So it's not looking at, let's say, positive parts of personality. So it's looking at the things that will maybe get you in trouble with other people or with your emotions. And the MMPI-2 is the most, it's actually the MMPI-3 now has been released, which is the most widely used. It's a self-report measure where you rate yourself in accordance to a number of questions. And then you can rate yourself, the clinician will score it for you in relation to these different areas. And there's multiple scales on it. And I guess the focus here is, how do you compare to the normal population on these problematic parts of personality? So for example, this graph on the right hand side shows that this person scores really high on 4, which would be the psychopathic deviate, which measures delinquency, etc. And then they also score really high on the hypomania, number 9. So hypomanic symptoms would be high for that person. And then social introversion is low, so that means they're not introverted, they're more extroverted. So that's why that's very low. So this person would be a kind of a very outgoing, chatty person with delinquent kind of tendencies. So as you may be able to imagine, this type of tool is often used in forensic services or in court cases. Amber Heard, or is it Amber Rudd? No, Amber Heard, I think, with Johnny Depp actually had the MMPI administered on her and didn't actually present her personality in a favorable light, but it presented information that was relevant to the court case. So another way to look at the dimensional symptoms focus is the ICD-11. So the EU or the WHO kind of classification of mental disorders. I'm not sure if it actually applies to general health as well. I think it does. but the ICD-11 is moving away from the categorical diagnostic kind of all or nothing, so it's moving away from you have a personality disorder or you don't, towards a more continuum based rating of personality. So whether you're in the mild, moderate to severe range of kind of personality difficulty, and then it's looking at broad domains which are listed there. So it's interesting that it's kind of moving towards that type of classification system, more towards the continuum. So it's good to be aware of that, I guess, as a GP, that's the general direction for the way things are going. In the DSM, we still have the categorical, so we still have those cluster A, cluster B, and cluster C, which I mentioned at the start, but there are alternative models being proposed. And this is one here. And as you can see, it's a bit similar to the ICD-11 one, where you kind of have a impairment rating. So no, some, moderate, severe, and extreme in terms of personality. And then you have the broad trait domains where you can rate personality in. So that's the kind of general direction that we're going. I think a big advantage of the continuum approach, or the kind of dimensional approach where you're kind of on a graph and you kind of can see your profile at different levels, is that it kind of inherently promotes the message that personality is flexible and that it can change. So it can change over time. So your graphs can change from high to a bit lower over time. And that's what we use in PATS. That's our understanding. Oh. Sorry, my microphone went again. So this is our understanding in our personality focused programs in St. Pat's. So this is group radical openness. And this is really targeting over control. As it says there, the way of coping is called an over control style of coping. So it's looking at over control tendencies. So it doesn't have that diagnostic approach, because the diagnosis, when you think of personality, implies that it's your personality and that it might not change. Whereas GROW kind of loosens the kind of label of the diagnosis, and one of the things is that it helps you develop safety and flexibility in 3 areas. So it helps you become more flexible in your relationships, rigidity, and emotions. And those 3 areas are very important for people with sort of an over-controlled personality style. Same with DBT. Over time, it was kind of, I suppose we talked about it in terms of initially we talked about it in terms of borderline personality disorder, but it's over time it's been sort of broadened to help people with emotional dysregulation and impulsive behaviors, and it's kind of looking at that as a group of symptoms or coping strategies that you want to be able to regulate or change the intensity of those emotions within programs like dialectical behavior therapy. So both of these are quite long programs, quite intensive, because it takes a good while to change your personality. So you need those intensive interventions. So those are the kind of dimensional symptoms focus, and those are the interventions that will help you with the dimensional symptom, like the problematic parts of personality. But the other kind of approach to be aware of, and it's growing within clinical practice. It's been, I suppose, widely known outside of clinical practice, but there's a growing kind of application clinically. And that would be towards a universal approach to personality. And that would be looking at things like the big 5 personality traits. So there's a huge amount of evidence behind these traits that you can describe human beings in different cultures across the world, different age groups, with these big overarching 5 personality traits. So they're not the only personality traits to describe human beings, but they found that they're common across human beings. So those would be openness to experience. So how open or closed you are, how flexible you are with new experiences. Conscientiousness, that's to do with your planning ability and getting things done. Extroversion, which is a big one. You might have asked yourself at some stage in your life, am I an extrovert or an introvert? The reality is that most people are neither. Most people, about 67% of us, are actually in the middle, because it's on a continuum, and the average range is going to take up the most of the continuum. And you also have agreeableness. That's kind of how well you can cooperate with people, or how disagreeable you are with other people. And neuroticism. So it also does have a kind of looking at sort of your tendency to experience negative emotions. So that is, if you think of how we judge other people, or how we assign what we think their personality is, we do tend to take into account neuroticism as well. Funnily enough, with the big 5 traits, it's been argued that it has a kind of an evolutionary focus, an evolutionary rationale behind it, and we can find the big 5 personality traits in animals like chimpanzees, for example, and as you can see here, even octopuses or octopi. I don't know what's the plural of octopuses, but you can even mark some of the personality traits within them. And for example, but our closest relative in the animals is chimpanzee, and the chimpanzee, and you can rate different chimps by their big 5 personality traits. And one that's kind of fun there is you can rate your dog in terms of neuroticism, agreeableness, extroversion, but you can't really rate your dog in terms of his or her conscientiousness, or how well how well your dog plans or is organized, because dogs tend not to be in that way. Another thing about the big 5 personality traits is you can actually drill down into what's called sub-traits. So it's not just focusing on the overall traits at the top. You can drill down. For example, neuroticism is made up of your tendency to experience anxiety, anger, depression, self-consciousness, impulsivity, vulnerability, etc. So there's actually 6 sub-traits underneath each of the big 5 traits. And clinically, that's actually the most useful part, because you can really break down a person's personality that way. So, for example, one that comes up often under agreeableness is trust. So trust can sometimes be very, very low, especially with people we see clinically. So if we can identify that in a personality profile, then we can look at the reasons for why that came about. And then we can start to say, okay, what would be experiences that you can have in life that would build up your trust with other people, or let your guard down in a very slow and safe way with other people. And I mentioned assertiveness earlier. That's actually a sub-trait of extroversion. That's one that, again, a lot of people clinically will have a very low assertiveness. So setting your boundaries with people, standing up for yourself, saying no to people, reducing your sorries to people, all of those things people need help with. Because I guess being a lack of assertiveness was your way of coping with the environment that you might have grown up with. And also clinically, you can use the kind of neuroticism subtraits as well, because they kind of map onto clinical treatments quite well. Yeah, I mean, you could all of the subtraits really you can look at, and I'm doing some work on that with service users in St. Pat's at the moment, looking at their personality profile, looking at areas that were kind of a surprise to them or were expected in terms of when I show them the results, and then I also asking them questions that they had about their personality and seeing can we answer them by looking at their profile and taking into account their history. So I've just started an initiative on that, and people generally tend to like that approach, and it's a very kind of evidence-based approach in that these concepts are very well supported. And a little bit more about that approach is that we can start to look at personality. We're looking at universal personality and a symptoms approach. We can kind of promote the message that its personality is normal, and we all have deviations of personality traits, and then we can bring in a kind of a theory called collaborative or therapeutic assessment, populated by popularized, by Stephen Finn, an American researcher and clinical psychologist. He came up with the concept of collaborative therapeutic assessment. So promoting the idea that you don't just assess someone's personality and tell them what their personality is, that you actually, through the whole process, you work on it together. You kind of look at the results together, develop questions together. And again, this is something I'm trying to kind of bring more into PATS. And so if you break this into steps, this approach, what you would do is in your first session with the client is you sit down and you formulate personality questions. So you write down literal questions, like, for example, do I have a EUPD profile or a borderline profile in my personality? Do I like to spend more time alone or with others? Why do I feel distant to other people? So those types of questions, that would be like your session one, would be like kind of coming up with those questions. Session two, the person would complete the assessment. And session three, you would discuss the findings and the insights and develop insights into the findings. For example, like you would look at were the results expected or unexpected, which results were the most, if they were really unexpected, that sometimes is something that to really reflect on and think, okay, what's that about? And then you can go back at this stage as well and answer those initial questions that came up in step one. And then finally, you can derive interventions, usually, I suppose, psychological interventions when I'm thinking of my own experience for those findings. So these can either look at acceptance or change. So what I mean is are there sorry, I definitely need to get a new headset. Sorry about that. So the interventions can look at acceptance, because that could be like, okay, I found out things about my personality in this assessment. Now I need to work on maybe accepting that. Maybe I'm unhappy with that, or maybe I don't understand it, or maybe there's emotions that come up about that, or maybe there's things in my life that shaped my personality in that way. So that's kind of acceptance-based interventions. And then you can have the change-based. So that would be like things like the DBT one I mentioned earlier, or the GROW intervention group program that we have in PATS as well. So you want to change parts of your personality. So that's a kind of a structured collaborative way that you can look into personality in, let's say, 4 or 5 sessions that you can do that in. Okay. So the final part of the presentation is kind of looking at the pros and the cons of these different approaches to personality. So we had those 3 areas. So the first one was the diagnostic approach to understanding personality in clinical practice. So if we look at some of the pros here, so we could say that it's efficient for treatment planning to have a kind of patients grouped into diagnosis, into personality disorder diagnoses. You can assign different interventions like group programs or individual therapy or whatever for particular diagnoses. It's a shorthand way to group service users. So sometimes in MDT meetings, knowing the personality disorder label or diagnosis, it can be a way for you to say, this person has EUPD or borderline personality, and then other people on your team will kind of get an instant recognition of what you're talking about without having met the service user. So sometimes that can be good for efficiency and understanding in teams. And on the service users side, it can give clarity. So I've met some service users in my work who like to have a diagnosis of a personality disorder. They feel like it fits their experiences, and it can give them clarity going forward. So those are the kind of the pros of the diagnostic approach. And the cons, I suppose, to give somebody a personality disorder diagnosis is arguably stigmatizing and pathologizing because of the way people with those diagnoses are treated in life. They can be sometimes, for example, if you heard someone referred to as a narcissist, so that would be someone that you want to get away from and not engage with. Or if someone is borderline personality disorder, it's automatically quite a negative thing about their personality. So it has, and people with those diagnoses have reported that they feel stigmatized or felt like an other as a result. And I think as well that a problematic thing really here is that the message is that your personality is disordered, and that's quite a hard thing to take, because there's almost an implicit implication that your personality it's slow to change over time. So if you say to someone your personality is the problem, it's like you're saying your whole being, your whole identity as a person is the problem, and that's going to be you can take the reaction to that, what might be, okay, I'm a big problem myself, and I'm not going to be able to change these things, and there's something fundamentally wrong with me. So that's quite different to having, say, a medical diagnosis where it's targeting a certain problem. To apply that to your overall personality is, I think, a very potentially damaging label to have. And another con with this really is it comes from the evidence base behind it. So there are classification issues with all or nothing categories. So it's in the research is showing that it's hard to group people into a category or not, that the validities and the psychometric properties behind that is not as strong as we would like. There's heterogeneity within categories. So we looked at borderline personality disorder at the start. So I said that there was 5 out of the 9 symptoms or traits that you have to have. There's a huge amount of combinations of the 5 out of the 9, as you can imagine. Like I don't know how many it is off the top of my head, but I remember reading it before, and it was a huge amount of potential combinations. So you can have people within a personality disorder who are very, very different in their presentation and who they are. There's overlap across categories. So somebody with one personality disorder is likely to have another personality disorder and another one, and sometimes 2 or 3. And that's problematic because ideally you want one kind of diagnosis and not multiple. And then there's indistinct boundaries with normal personality. So even with borderline personality disorder, as I mentioned at the start, we can sometimes see aspects of that ourselves. So we have a little bit of those traits. For example, impulsive behaviors. So lots of us will have drank too much or gambled too much, and so on. And that's a lot of that is in the general population. So, but when you look at diagnosis, again, it's back to that thing. It's kind of like what's normal and what's abnormal in that, and it's hard to get that boundary. And the biggest thing just to keep in mind is that this way is kind of on the way out. This way of looking at personality is on the way out, with the ICD-11, for example, moving towards the dimensional system, and alternative approaches being proposed for the DSM. So that's it's the main kind of way to look at personality now, but in the future, I would have my doubts, like in 10 years, if we're still talking about personality disorders and the different clusters like that. The second approach that I looked at was contextual approaches. So this is all kind of looking at the context of someone's life and how that shapes your personality. So a good kind of a good aspect here is that it validates experience. So it says, okay, this is your personality now, that makes sense in relation to what you've been through. So maybe you don't trust people, but that completely makes sense based on your upbringing where your trust was broken in close relationships. The contextual approach also emphasized changeable coping strategies. So it's kind of like, this happened to you, this is how you coped, and you consistently cope in that manner. So you consistently distance yourself from other people when it gets a bit if you feel a bit uncomfortable, you kind of pull back a lot. So that's a coping strategy that you have, but that's also changeable. And then also, yes, so it puts issues in the context of your life experiences, the culture you grew up on, as well. The cons here would be that there is probably an overfocus on interpersonal issues like attachment and trust and your relationships with your family and how they shape your relationships with other people as an adult, because that's not all of personality. It's one aspect of personality. There's lots of measurement issues here. So measuring attachment as an adult compared to how you were, how your attachment style was as a child it's hard to get the data on both time points. So there's lots of measurement issues around attachment. And if you're looking at contextual approaches as a whole, there's a huge amount of variance in the different approaches. So there's no real kind of gold standard way to do this. It's kind of a broad formulation approach. So there's maybe a lack of precision here. And then finally, the final one is the dimensional approaches to personality. So the pros here would be putting people on a continuum shows that, okay, I have a certain amount of a score on this personality trait, but maybe other people have some amount of that personality trait, and I can see myself on a graph compared to them. I'm just in the high range. I'm just above the average range, let's say. So, okay, I'm not that weird. I'm kind of normal in that way. And the full depth of personality is covered in these dimensional approaches, especially if you use the universal approach that also has that neuroticism bit. And the message here is that change is possible. So if you're on a continuum, it fluctuates over time. The evidence is the personality fluctuates over time. So you're not stuck with a disorder for the rest of your life. It can change over time, and that gives people hope, and that gives people the motivation to do psychological interventions, for example, targeting sorry about this now. Let me just charge that there. Sorry again about that. Yeah, so it gives that message that change is possible with the dimensional approach. And the cons here, well, firstly, if we look at those symptoms-based approaches, like with the MMPI, that's just focusing on difference. So how you as a person, if you're in a mental health service, how you are different to the normal population or the general population. That can be an overemphasis on what's wrong with you, rather than how similar you are to other people, which can be stigmatizing. The universal approach, like the Big Five, doesn't have that problem. But a problem it does have is that more clinical applications are needed. I suppose for a long time there's been, I think, skepticism amongst clinicians about the clinical utility of the Big Five personality traits and similar systems like that. So the bias, I guess, is to focus on or the preference, I should say, is to focus on the negative side of things, which I kind of disagree with. I'm kind of promoting, I guess, that universal approach, because I think there's a lot of different applications and empowerment within that. And thinking about, I mentioned personality change a good bit so far. You have to realize that would be a very slow process. So it's not going to happen overnight. It takes a long time to change your personality or aspects of your personality, mainly because these are behavioral tendencies that you've grown up with. They've evolved over time, but you can't change none of us can change our personality next week or next month. We can change our personality within the next 5 years. That's much more realistic if we start creating experiences for ourselves, working towards certain goals. We can do that over that length of time, but sometimes that's not very attractive for clinical services, and when there's financial implications and things like that, for can people afford treatments? Sometimes people want a quicker fix than that, understandably. But if you stick with it and you kind of have the general compass or direction that you're going in, and the things that you want to do for yourself and your personality and the ways you want to develop, that's how you kind of can have success with it. So if you say to yourself, where do I want to be in 5 years' time, or what type of person do I want to be in 5 years' time? That's the type of patience and the time frame that it takes. So I'll just let you have a look at that for a minute yourselves, and I'll just have a drink here. You can summarize that yourselves. Okay. And so, in summary, personality, characteristic patterns of thinking, feeling, and behaving. That what permits prediction of what a person will do in a given situation. And then finally, I've looked at the pros and the cons of the different approaches. But really, it's your choice which one that you want to promote yourself. And to make that decision, I guess you can listen to me or take on board my opinion if you like. But I suppose evidence-based practice and the best decisions for the service users will take into account the three factors together: the best scientific evidence, your clinical judgment and experience, and whatever you think that your patient would be good for, what your patient would value. So we need to sometimes ask the service user what approach they would think is the best for them. And if we can get the three of those together, if it feels right in our clinical judgment, if the evidence is in line with it, and we're taking into account service users' values and opinions, then we can generally be in a good place, especially with mental health interventions. Okay, so that's about it from my presentation. Thank you very much for your attention. I will just see if there are any questions. I think if there are any questions, you can feel free to write them in the chat. I think we have a Q&A here, but if you've no questions, that's absolutely fine too. But it was great to be with you here tonight, and I hope you've taken something from it. Oh, I might have a question. Many thanks. No problem.
Thanks so much, Conal, for
Okay.
that. That was a really excellent presentation, and you managed to fit a lot of information into the short time frame. So I really appreciate you taking the time this evening.
Oh, no problem. It was a pleasure.
Have a couple more thank yous in there as well, which is great. So we hope that those in attendance this evening found it as useful and informative. There doesn't seem to be any questions there, but if there is anyone who has questions after tonight, you can email them to communications@stpatricks.ie and we will pass them on to Conal. And just to say, when we sign off this evening's webinar, you'll see a link on your screens where you can share your feedback, and we'd love to hear your thoughts to help us improve future events. So if you have 2 minutes, please do follow the link and share your feedback. And lastly, CPD points from the ICGP are available to any GPs who have attended this evening's event, and they'll be sent to you automatically over the coming 4 weeks. A recording of the webinar will also be made available on our GP CPD portal at stpatricks.ie/GPs referrals. So that's it from us tonight. Thank you all very much for joining us for this evening's event. Night.
Thanks, everyone.